Good afternoon. At the outset, I am thankful to AIS for the invitation and the opportunity. I'll be presenting my talk on complications of glaucoma drainage devices. Uh, as we all know that glaucoma drainage devices have become mainstay of management of refractory and complicated glaucomas, and they come with their own set of issues and complications of implants can be in fact valve related to the structure of the implant, and they could be surgery related complications also. And valve related complications can be hypotony and hypertensive phase. Hypotony, in trabeculectomy patient, hypotony can occur and mostly it's not serious. But with implants, I am always worried about hypotony, and if there is associated shallow chamber, then it's even more grave. And the causes can be, apart from the valvular issue, can be leakage from the surgical site, implant misfunction, or there could be choroidal detachment, cyclitis, perforation during surgery, aqueous hyposecretion due to ciliary shutdown, or sometimes there can be inadequate capsular formation due to various reasons. And this is the flow chart for management of hypotony. If we have small conjunctival leak, we can primarily repair it. However, if there is scleral leak, we have to sometimes put the scleral patch graft. And if there is a device failure, then revise the surgery. Choroids, if they are small, conservatively managed. If they are large kissing choroids, we may have to go surgically and drain them. And if there is perforation, inadvertent perforation while passing the suture, you have to either laser it or do cryo application. And then do the buccal also sometimes has to be applied. And this is kissing choroids. Such cases will require eventual drainage, otherwise they are not going to settle with conservative treatment. However, hypotony is not always benign. Sometimes it can be very sinister, underlying issue can be quite serious. So like this patient had, after a week or so, started developing hypotony, and when we looked at the bleb, the patch area, the scleral patch was melting. So we went ahead and put another patch. Again, after a week or so, it started melting again. And then we started thinking that something is wrong, and now taking history and examination, which we miss as ophthalmologists. We are really focused on eye only. We hardly see the patient systemically. This patient had hand deformity. So had we been vigilant, we would have picked up. Patient had rheumatoid arthritis in the past. It was treated, and right now it was not active. But patient having autoimmune diseases, after surgery it gets reactivated. And then with the help of rheumatologist, we started immunosuppressive, all anti-inflammatory drugs, did another surgery, but sometimes nothing works. We were not able to save vision in this patient. And lesson learned is that if we should be looking at systemic picture also. We should always take history. If patient is having any autoimmune disease, we should not be doing implants. So these are not ideal candidates for glaucoma implants. Then trabeculectomy will be a better option. And sometimes hypotony can be having another serious issue like malignant glaucoma. So this patient, after a week or so, started developing hypotony with shallow chamber. And since there was hypotony, pressure was low, we were not suspecting malignant glaucoma, but then chamber was uniformly shallow. So we did UBM and picked up, it was anterior rotation of ciliary processes, and patient was having malignant glaucoma and responded well to pars plana vitrectomy. So coming to hypertensive phase, before we label patient as hypertensive, we have to rule out outflow obstruction. Because if outflow obstruction is there, again IOP will be high, but it won't be true hypertensive phase. So outflow obstruction can be because of the vitreous, can be because of blood clot, fibrin, sometimes cortical matter if patient has been operated for cataract surgery in the past. So like this patient had, you can see the strands of vitreous going into the opening of the tube and blocking it. So this patient responded well to vitriolysis by ND glysis, and the IOP was controlled after vitriolysis. So this patient in fact won't be included into hypertensive phase. True hypertensive phase can occur early, like after 3 to 6 weeks, or later after 4 to 6 weeks of the surgery. And it occurs due to excessive fibrosis of the fibrous capsule around the plate. And local examination will show inflamed congested eye with tense bleb, and IOP will be to the tune of 30 to 35 millimeter mercury. And it's more commonly seen with valvular devices. AGV has almost 40 to 80%, whereas with ADI or Berwald it's little less. And with the current model, the silicon model of AGV, the incidence is less as compared to polypropylene models. And management of hypertensive phase, mostly we manage them conservatively with medication. We start anti-glaucoma medication and observe the patient for 4 to 6 weeks. There is spontaneous resolution because of the remodeling of the capsule around the bleb. And if it doesn't respond, and after 4 weeks also pressure is high, then we can go ahead with the mitomycin C, bleb needling, suture lysis, and the revision of implant if it's shunt failure. And sometimes we have to do revision of the bleb. We have to remove fibrous capsule, remove excessive tissue, and then resuture the conjunctiva, and then it start working again. The structural complications can be outflow obstruction, conjunctival erosion, implant exposure, tube migration, or diplopia. This we have already discussed. Sometimes there is blockade from the tube to the end plate, and or could be outflow from the end plate. So this has to be, we have to intervene surgically and remove the obstruction, because we can't manage it with laser. It's all covered area. We have to intervene, try to remove if there is blood clot or whatever material has entered the tube, and it may start working again. Conjunctival erosion around 10% of the patient. And remember, the implants are done in patients who have undergone multiple procedures. Patient has undergone vitreoretinal surgery, maybe trabeculectomy, cataract surgery, penetrating keratoplasty. So conjunctiva is always an issue. So the other factors like immune related melt, excessive tension, then rubbing, trauma, or dry eyes very prevalent. So all these factors can further lead to corneal erosion. And if it is small conjunctival erosion, we can directly close it, or sometimes we have to use conjunctival autograft from the same or the other eye of the patient, or amniotic membrane can also provide a good cover. And if it is recurrent, then probably we have to explant, because then there is risk of endophthalmitis, which is more serious problem. Tube migration can occur in 3% of cases. Surgical repositioning of tube is required. Diplopia can occur especially with Barweld or ADI. It's less common with Ahmed, but most of these patients can be managed with prisms only. And one of our patients had trauma, child 5-year-old, undergone implant 3 months ago, and then she didn't inform the patient. Children, they are scared of the parents, and once they came to us, this was the picture. Along with, there was perforation, corneal perforation, and tube was extruded. So we took her to the operation theater, and 2.5 millimeter sclerocorneal graft was implanted and tube was cut, and luckily this child was okay with postoperative medications. And then surgery related can be corneal decompensation, endophthalmitis, malignant glaucoma, hyphema, and cataract. Corneal decompensation is real issue. So all eyes after implant, they show reduction in the endothelial cell count, and this is the closeness of the tube. Basically it's mechanical trauma due to endophthalmodosis, or during sleep time some patients have habit of sleeping in prone position, then tube can really come into contact with endothelium and decompensation, requiring further keratoplasty or future keratoplasty. So early, sometime you can trim the tube, you can reposition the tube, And we can apply a suture also, which will keep the tube in place away from the cornea. And keratoplasty, if decompensation occurs, and we can put the tube in pars plana, so that will save the endothelium. Or other simple alternative is put the tube in the sulcus, like post penetrating keratoplasty glaucoma in pseudophakic eyes. I always put implant in the sulcus. So this is our study of 66 patient. So we found that there was no difference in IOP control in both the groups. However, the anterior chamber ciliary sulcus placement had better outcome as far as endothelium was concerned. So endophthalmitis, hyphema, again they have to be treated. Endophthalmitis, intravitreal antibiotics or vitrectomy, pars plana vitrectomy if there is no response. And every surgery has its own set of complications. So similarly, implants have their own problems. The difference is that post-trabeculectomy complications are milder and they can be managed conservatively, but complication of implants are more serious. So there is tube inside the eye, so we can't ignore them. So prompt recognition and management of these complications will make our surgery successful. Thank you.
Good morning, Dr. Suresh.
Dr. Parul.
So with the new AGV valve, which has a smaller lumen, do you also experience a longer hypertensive?
Definitely. In GSI also we were discussing.
What are you doing about
it? I mean, in last 2 years, 1 year ago, there were few implants. We were not able to do.
There are no financial.
Pause. Karo.
We were not able to do, irrigation. The lumen was so small. So now they have withdrawn that those
Have
implants.
the new ones come?
Yeah, newer ones are okay.
The previous type?
Yeah, they have reverted back to normal. So there was one batch or few batches which have very small lumen that the irrigation was not possible. So it happened with lot of people.
So, because
they
earlier we had
also.
older ones lying with us, so I just used two and I had a bit of problem in the hypertensive phase. It was very prolonged.
Hypertensive phase is because of the material also and valve. So in valvular devices of AGV of polypropylene, it was very, very high. Up to 80% has been reported. But with silicone implants which are currently available, it's much lesser. So studies have shown that it's less than 40%. So I think we have totally shifted to silicone model now. So hypertensive phase is lesser issue now.
So one question.
And
So with the newer models of the silicone AGV, do you feel that they are slipping when we are switching the plate suddenly? Like I have not seen it before, but suddenly in the last 6 months, I feel that they're just slipping into the orbit and we have to retrieve them again and again.
they're more soft, very pliable.
So do you put a
some
suture
you have to
before?
hold them little carefully. So they are not as rigid as polypropylene.
It's something which you have experienced too.
It's material related.
It's because of the material.